Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 532 of our pharmacotherapy series, which majors in anxiety disorders. The next case reads, SSP is a 17-year-old young man who is brought to the hospital by his mother. SSP is barely conscious, and his breathing is slow and shallow. His mother states he took a whole bottle of diazepam, 5 milligrams containing 30 pills, sometime during the previous night. SSP's medical history is significant for a severe head injury sustained from a car accident 8 months ago. He currently takes carbamazepine, marketed as Tegretol, 200 milligrams thrice daily for seizure prophylaxis. SSP's mother believes diazepam is the only drug he ingested because no other medications are missing. Toxicology is positive for benzodiazepines and negative for other substances. So my first question to you reads, what signs and symptoms are consistent with benzodiazepine overdose? Why is it inappropriate to administer the benzodiazepine antagonist, flumazenil, in this case? Benzodiazepine overdose is characterized by respiratory and CNS depression, both of which are evident in this case. SSP is almost unconscious, with slow and shallow breathing. Overdose with benzodiazepines as the sole ingested agent is rarely life-threatening, and full recovery is the usual outcome. Flumazenil is a benzodiazepine receptor antagonist effective in reversing sedation associated with benzodiazepine intoxication. Its effects on respiratory depression are inconsistent, but improved breathing may occur secondarily to increased consciousness. The primary use of flumazenil is in reversing benzodiazepine-induced conscious sedation, primarily with midazolam, in patients who have been sedated for minor surgical or diagnostic procedures. Flumazenil is also approved for treating benzodiazepine overdose, but this use is controversial because of potentially serious complications, e.g., supraventricular arrhythmia and seizure, and questions about its cost-effectiveness. Flumazenil administration does not appear to decrease mortality or length of hospital stay in cases of benzodiazepine overdose. Therefore, its use for this purpose has become limited. Flumazenil is contraindicated in overdoses of any agent that decreases the seizure threshold, such as tricyclic antidepressants. Toxicology screening and an electrocardiogram should be performed before flumazenil is administered. Because of a risk of seizures, flumazenil should also be avoided in patients with increased intracranial pressure or a known history of seizures or head injury, in those who have been receiving chronic benzodiazepine therapy, and in patients with a history of recent illicit drug abuse, involving cocaine or heroin. Administration of flumazenil should occur only when acute seizure management measures are available. Flumazenil reverses benzodiazepine-induced sedation or coma within 1 to 2 minutes after IV administration. The most common side effects include agitation, dizziness, nausea, general discomfort, tearfulness, anxiety, and a sensation of coldness. Rapid or excessive infusion has been associated with tachycardia and hypertension. The elimination half-life of flumazenil is 41 to 79 minutes, and sedation may recur after 1 to 2 hours, especially when large doses of long-acting benzodiazepines are involved. Repeated flumazenil doses or an IV infusion may be indicated in these cases. Full recovery should be verified, manifesting as 3 to 4 hours of stable alertness, before patients are discharged after flumazenil administration, and they should be advised to avoid driving or performing other potentially hazardous activities for 24 hours. Flumazenil undergoes extensive hepatic metabolism to its glucuronide conjugate and de-ethylated free acid. Dosage reductions are recommended in patients with liver dysfunction. Flumazenil is not appropriate in SSP's case because of his history of head injury and risk of post-traumatic seizures. Instead, management should involve general supportive measures and mechanical ventilation, if indicated. A psychiatric evaluation is also indicated in this case to identify and address the reasons for SSP's overdose. The next case reads, BIG, a 68-year-old man, is brought to the emergency department, abbreviated as ED, by his wife after being involved as the driver in a minor car accident. He has no physical injuries except for several small abrasions caused by the car airbag deployment. However, BIG appears drowsy, is mildly confused, and has an unsteady gait. A toxicology screen reveals no alcohol or other substances, except for clonazepam, which his physician prescribed several months ago. BIG's wife states he has been taking 0.5 mg twice daily, and it has been remarkably effective in improving his mood and anxiety. BIG, who is 5 feet 8 inches tall and weighs 250 pounds, is a recovering alcoholic with moderate liver disease caused by years of heavy drinking. He has successfully maintained his sobriety for nearly 2 years. In addition to clonazepam, BIG also occasionally takes over-the-counter omeprazole and C-metadine for heartburn. It is determined BIG is experiencing adverse effects of clonazepam, probably caused by drug accumulation. My first question to you reads, what factors could be influencing disposition of clonazepam in this patient? Benzodiazepine pharmacokinetics can be affected by various physiologic factors. Several of these factors are present in this case and may have contributed to the accumulation of clonazepam with resulting adverse consequences. BIG's age may influence clonazepam disposition. Reductions in both CYP3A4 and CYP2C19 activity have been reported to occur with aging. The glucuronidation metabolic pathways are minimally affected with age, so no such effect is seen with lorazepam or oxazepam. Other factors contributing to longer benzodiazepine half-lives in the elderly include decreased hepatic blood flow and increased volumes of distribution of lipid-soluble compounds, owing to decreased muscle mass and increased fat. The latter can increase a drug's half-life in the absence of any clearance changes. Older patients are more sensitive to the sedative and psychomotor and especially cognitive impairing effects of benzodiazepines. For these reasons, benzodiazepines should be avoided in the elderly, but if necessary, then the recommended benzodiazepine dosages for patients older than 65 years are generally 1/3 to 1/2 of those used in healthy adults. Sex also may influence benzodiazepine clearance, but studies yield mixed results. Women have been reported to have higher CYP3A4 and CYP2C19 activities than men, which may partially explain these findings. Increased CYP3A4 activity in women disappears after menopause, which may necessitate the use of lower benzodiazepine dosages during the postmenopausal period. Women have slower glucuronidation metabolic processes than men, resulting in lower clearance of agents such as temazepam and oxazepam. Obesity and liver impairment are other physiologic factors relevant to BIG's case. Obesity increases the volume of distribution of benzodiazepines and the extent of accumulation of long-acting agents. Significant changes in the elimination half-lives of lorazepam and oxazepam are not observed in obese patients. Liver dysfunction can reduce benzodiazepine elimination rates and prolong their half-lives, resulting in recommendations for decreased dosages. The pharmacokinetics of lorazepam, oxazepam, and temazepam are unaffected by liver disease. Decreased protein binding of benzodiazepines can occur in patients with renal insufficiency, which may lead to increased free fractions of highly protein-bound agents. However, no significant changes in clearance or volume of distribution of free drug have been noted. Regarding ethnicity, up to 25% of Asians are CYP2C19 poor metabolizers. Decreased clearance of a variety of CYP2C19 substrates, including diazepam, has been reported in Asian subjects. In summary, the physiologic factors that can alter benzodiazepine disposition in BIG are his age, obesity, male sex, and liver disease. Accumulation of clonazepam owing to these combined effects probably led to his mental status changes. In addition to these factors, cimetidine and omeprazole can both increase the exposure of clonazepam, resulting in decreased clearance and increased side effects. If continued benzodiazepine therapy is deemed necessary for BIG, lorazepam or oxazepam would be preferred agents because they are least affected by aging, obesity, liver disease, or drug interactions. Benzodiazepine dosage equivalencies, which are based on relative potencies, can be used to determine an equivalent dose for the selected agent. However, these equivalencies are inexact, and dosing conversions should take patient variables and usual dosage ranges into consideration. For example, BIG had been taking 1 mg per day of clonazepam, so the calculated equivalent lorazepam dosage is 3 to 4 mg per day. Because of his age and recent reaction at this dose, a somewhat lower initial dose of 0.5 to 1 mg twice daily would be indicated, accompanied by careful monitoring for adverse effects or withdrawal symptoms. However, switching to a non-benzodiazepine agent should be considered because this may be a better treatment option for BIG. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 533.